Hello and welcome to the presentation on measles, also called as rubiola, not to be confused with rubella, by Dr. Ignatius Gold. This is Dr. Ignatius Gold. So, talking about the etiopathogenesis of measles, measles is a RNA virus belonging to the paramyxoviridie family. There is a picture of the measles virus structure. So about the transmission of measles. So measles is transmitted by droplet spread from the secretion of nose and throat, usually 4 days before and 5 days after the rash. So measles is a highly contagious disease and secondary attack rates in susceptible contacts exceed 90%. So pathogenesis. The portal of entry is the respiratory tract. The virus multiplies in the respiratory epithelium. The primary viremia, the infection of the reticuloendothelial system occurs, and in secondary viremia, the systemic symptoms occur. Incubation period is 10 days. Measles is common in preschool children. The infants are actually protected by transplacental antibodies. The IgG antibodies transfer from the mother. The effects of transplacental antibodies decline by 9 months, hence the vaccine is given at the age of 9 months. So the prodromal phase, the symptoms are fever, rhinorrhea, conjunctival congestion, and dry hacking cough. The conjunctival congestion is given in the picture. Koplik spots. The Koplik spots were discovered by Henry Koplik, and they are pathognomic of measles. They appear on the second or third day of illness. They are gray or white colored grains of sand-like lesions with surrounding erythema. They appear on the lower second molars on the buccal mucosa. These Koplik spots are given in the picture. So rash. Rash appears on the fourth day with a rise in fever. The rash are initially faint reddish macules behind the ears, along the hairline, and on the posterior aspect of cheeks. Rash rapidly becomes maculopapular and spread to the face, the neck, chest, arms, trunk, thighs, and legs, in that order over the next 2 to 3 days. So you can see in the picture, this is the rash appearing behind the ears, along the hairline. So this picture shows the rash of measles appearing on the trunk, and in the picture there's rash on the face as well. How do we differentiate between another very common disease, chickenpox and measles? In chickenpox there is headache and fever and tiredness or fatigue, and rare spots that appear on the chest, face, and the back. There's also decrease in appetite, and the maculopapules turn into vesicles and pustules, and there is crusting of vesicles, and the crops of vesicles appear. But in measles there is maculopapules, there are no vesicles, there is cough, sore throat, and conjunctival congestion. So this picture demonstrates how to differentiate chickenpox and measles. About the rash of measles, it will fade in the same order that it appeared and will leave behind a brownish carmine and brownish discoloration that fades over the next days. It takes about 10 days for the rash to fade. So what are the complications of measles? The complications are more frequent in the very young, the malnourished, and the immunocompromised. The complications are otitis media, bacterial bronchopneumonia with superinfection by bacteria, laryngitis, tracheitis, bronchitis, giant cell pneumonia when the measles itself causes pneumonia. There can be also flaring of latent tuberculosis and bronchiectasis. So gastrointestinal complications like persistent diarrhea, appendicitis, hepatitis, and ileocolitis may be present. And there can also be noma or gangrene of the cheeks. Other complications include acute encephalitis, which occurs in 1 in 1,000 patients, post-measles encephalitis, and the fatal subacute sclerosing panencephalitis, SSPE. SSPE occurs in 1 per 1 lakhs, and it is seen several years after infection. It is fatal and it is incurable. So the diagnosis of measles is mostly clinical. An IgM anti-measles antibody will be present 3 days after the rash and will persist for 1 month. Differential diagnosis. Rash is milder and fever is less prominent in rubella, enteroviral, and adenoviral infection. In roseola infantum, the rash appears once the fever disappears, while in measles, the fever will actually increase with the rash. In rickettsial infections, the face is spared, while it is always involved in measles. On the differential diagnosis, meningococcemia, in which the upper respiratory symptoms are absent, and the rash rapidly becomes petechial, and even can become ecchymosis. So this picture shows meningococcemia. Another very important diagnosis is Kawasaki disease. So these figures show the symptoms of Kawasaki disease, the fever, the bilateral non-purulent conjunctival injection, that is reddening of the eye, the injected pharynx, injected lips, and the typical strawberry tongue, the edema, the erythema of the hands and feet, followed by desquamation, the polymorphic rash, and the cervical lymphadenopathy. Treatment is supportive. It involves the use of antibiotics like paracetamol, maintenance of hygiene, adequate fluid and caloric intake, humidification of the environment, and a single dose of vitamin A is found to increase the immunity as well as resolve measles earlier. The best way is to prevent measles itself before it occurs. The vaccine is the measles vaccine, the Edmonton Jaguar strain, which is actually a live attenuated vaccine. It is given subcutaneously. It can be monovalent or given as measles rubella or as measles mumps rubella vaccine. It can occur from 9 months to 12 to 15 months. It can be given at 6 months of age during the outbreaks. The side effects can be fever or transient macular rash. The vaccine is incredibly safe and should be used rather than suffer the consequences of measles. Recently, due to the anti-vaxxer groups, measles has made an outbreak in America. Measles is actually near to eradication before this happens, so please give measles vaccine to the children near you and to your child. Thank you. Please subscribe if you like this video, and if you want more videos like this, subscribe to my channel, comment on it. Thank you.